my experience is really, as you've said, that if I look at, as a group, patients receiving alectinib in the stage 4 setting versus those in the early, it does seem to be a little better tolerated in the stage 4 setting. And one possible explanation is when you are diagnosed with a stage 4 cancer, generally you have symptoms, because these aren't typically picked up on screening. Someone with symptoms, with advanced disease, and often one of those symptoms is fatigue from the cancer. You give an effective treatment like alectinib or lorlatinib, people get better.
Yeah.
And so your starting point is here, you're improving. Now, after surgery, you recover from surgery, those patients are well, and they are potentially cured. Yeah. And if someone's asymptomatic from their cancer, you cannot make them feel better. Yeah. You can make them feel worse, and we often will do. And so that degree of fatigue, it still may be causing the same amount of fatigue, but if you're starting with no fatigue, now you're in the minus. If you're starting with a lot of fatigue, maybe now you're in the plus. So I think that is something I've noticed as well, and I would say, I have to look at my data, but I would say my dose reduction rate is probably higher in the early stage than in the late stage. The adjuvant setting, you mentioned duration as well. And with Alina, it was 2 years. As you mentioned, arbitrary. With Adora, it's 3 years, also arbitrary. And there are some that might say you need to stay on for longer. Laura, we're asking someone to take 8 pills a day for 2 years. Is that something that people are going to be very hesitant to do? And is 2 years too long to ask for a therapy like that?
I think it really depends on the patient. As you said, some patients might think, I'm cured, why do I need to take all these pills every day? But I think a lot of patients also, never want to do that again. And so they are willing to do whatever it takes and to take the pills and to tolerate some of the toxicities. Again, I think maybe the threshold there of what is considered tolerable is a little different for those patients compared to maybe the metastatic setting. But it can vary across the board. But I think generally patients, if they're taking it and they're tolerating it well, will probably want to stay on longer than 2 years.
Oh, so maybe the other way around. Mary, do you ever see that where people are hesitant to stop?
Yeah. I think it's a whole learning space for all of us, isn't it? But absolutely. Patients don't want to stop
because it's working.
Because it's working, and they're fearful, aren't they? I say fearful,
understandable.
But it's probably much more worrisome for the fear and the uncertainty of what their life will be if they do stop these cancer drugs that are we do see
things
them.
away. Absolutely.
Yeah.
Shirish, we're giving treatments. We talked about monitoring for side effects, monitoring for labs. Can you just briefly, in the adjuvant setting and in the metastatic setting, we're ordering scans to monitor progress, to watch for recurrence. What's your schedule there? How are you monitoring?
My sort of monitoring schedule, I don't know at the present time at least, is different for ALK-positive lung cancer than I would for any adjuvant therapy. But sort of monitoring with scans every sort of 6 months, 4 to 6 months in the first year, then every 6 months for the second and third year, and then sort of yearly. 2 things I think are, I don't do routinely brain scans in patients who don't have ALK or EGFR lung cancer in the adjuvant setting. There's no data, but I'm doing brain scans in these patients, not necessarily at every time I do CT scans, but I sort of do some sort of surveillance of the CNS. And I think that that is one thing that is one of the concerns for me as a provider, because I have seen, at least in stage 4 disease, brain recurrence occur even 6-7 years later when other sites of disease is controlled. And when you look at in the Alina data, this was one area where there was a clear difference, that the CNS recurrence rate was significantly lowered with adjuvant alectinib as compared to adjuvant chemotherapy. So I do brain surveillance, and that is one reason also where I myself as a provider is somewhat reluctant to stop in these patients, because I just don't have tools to understand who is at risk for developing not just recurrence, but particularly CNS recurrence, and who is not. And I think this is, there's a lot of needs still in advanced stage disease. I think this is one of our urgent needs in early stage disease in ALK-positive lung cancer, is to, whether it is minimal residual disease assessment or other such tools, to truly understand who is in need of adjuvant therapy, because not everybody is in need of adjuvant therapy.
Who's already cured?
Cured.
Who can we spare other therapies completely?
And then could it be a tool to understand what is the length of time that we should be doing this? I mean, we're doing this completely blind right now, and as much as we are excited about the adjuvant data, in some ways, as we get excited about that data, it does bring out certain frustrations as to, okay, we still don't know a lot of different things as to, whether to give chemo or not, whether to give, I mean, yes, we tend to do chemo, but, that's based not on data, that's based just on extrapolation from other subsets, and then the length of time of treatment.
Laura, patients generally okay with doing scans that frequently?
I think so. There's a lot of scanxiety, as we call it, the anxiety related to scans and waiting on those results. Sometimes a patient might have a scan, they may not see us for another week. And in today's day and age with the portals, everybody has access to their own reports, and whether or not the patient reads those reports is often dependent on the patient. And it can be very stressful for them to be waiting for those results. And even if they see the report, maybe there's something we need to check with our radiologist about. Maybe it's not exactly what we're seeing on the images, and just needs a little bit more digging to go over before we can really talk about what those results are with the patient. So I think there is a stress level around scans, but I think patients are often wanting to know what's going on and wanting to have those scans for some kind of reassurance or guidance in which direction this is going.
Mary, similar experience?
Yeah, absolutely. And I think it's absolutely right. Scan anxiety is real, will always be real. And I think the challenge for us in our healthcare systems that we work in is how can we get the scan, get it reported and see the patient in the shortest time frame possible. And I think there's an onus on us in the healthcare systems to try and we can probably influence some of that.
Yeah, we have to do our best to really minimize the anxiety. It's a big impact on quality of life.
Huge.